Bismillah ar-Rahman ar-Rahim. Good evening, everyone. Thanks all for attending this session and this weekend. We are continuing our neuromuscular series, and tonight will be basically for the treatment for myasthenia gravis. Our speaker today is Dr. James Howard, who is a former distinguished professor of neuromuscular disease and prior chief of neuromuscular disorder section at University of North Carolina. He is currently a professor of neurology at UNC and directs also myasthenia gravis clinical trials. Dr. Howard has been practicing neurologist over the past 41 years. His main focus are on EMG and myasthenia gravis. Dr. Howard is a leading expert in myasthenia gravis and has authored more than 110 abstracts, 150 articles, 35 book chapters, and 3 books. He was the 2019 recipient of European Academy of Neurology Investigator Award. Dr. Howard, the floor is yours.
Thank you for the invitation to speak with you today. And today we're going to talk about complement inhibition as a treatment paradigm to treat generalized myasthenia gravis. These are my requisite disclosures. I consult for a number of pharmaceutical companies in the development of new therapeutic agents for myasthenia gravis. The list is here, and have other research support from foundations and our government in terms of myasthenia. Back in October, this editorial appeared in the Green Journal of Neurology. People with myasthenia gravis are getting better, but are they really doing well? And that was really a wake-up call to all of us. And I think we would all agree that we've done pretty well using the tools we have in our toolbox to treat myasthenia. But I'm going to try and show you some data that suggests that while we think we are, we probably aren't. You're all well aware of the tools in our toolbox that range from immunosuppressive therapy with corticosteroids and azathioprine, the cyclophilins, mycophenolate, etc., as well as immunomodulatory therapies with immunoglobulin, with therapeutic apheresis, and most recently with eculizumab and efgartigimod. And we have symptomatic therapies as well, and in some individuals, thymectomy plays a critical role in our overall treatment program. Everyone, or each of us geographically, has different access to these tools, and it's based on the rules of our health ministries, and in the US, our insurance companies. So each of us uses different tools within our toolbox based on what we're allowed to do or what we have access to, and I'll speak in broad generalizations about this. This slide shows that we've really done pretty well in terms of mortality, as you can see here. In the early 1900s, we had some 90% mortality, typically respiratory failure. And with the advent of antibiotics and ventilation, we clearly made a precipitous decline in the mortality rates. And then beginning in the early 60s, carrying through to the present time, we've added new immune therapies to our program that have chipped away at this mortality rate, so to speak. And now probably somewhere between 2, 3, 4% mortality due to MG. And some would argue that this is fantastic. that we've made tremendous response. I'll agree with that. But we need to look at those who we don't serve well. And in one of those is a population of patients who have failed to respond to the therapies that we've provided them. And it's arguable, but some say between 10 and 20% of our myasthenic patients that have been termed refractory. I don't like that term because virtually every patient improves to some degree, and they're not totally resistant to therapy. That's a rare individual. And I would prefer to use the term poorly responsive to therapy. But beyond that, I would suggest that probably up to 60, maybe even as high as 65, 70% of patients still have unmet needs based on the therapies that we use. When we look at the myasthenia gravis activities of daily living score and a myasthenic specific quality of life instrument, and these are data cuts from a registry a few years ago, we see a totally different picture. Higher scores mean worse disease or worse affliction. And when we do a cross-section of this registry database, and I agree registries have their limitations, one sees that more than half of individuals have MG-ADL scores in excess of 6, indicative of moderate to severe disease. And on the right side, you see their quality of life instrument. And this impacts, or this looks at psychosocial aspects, day-to-day well-being, etc. And one sees this broad representation of the QOL. And scores above 15, 20 are indicative of poor quality of life. And the question has to come, if we've done so well from a physical perspective, what I call disease burden, what's impacting the treatment burden, all of the other aspects of quality of life in these individuals. And so there have been some satisfaction surveys that have been performed, again, through the Myasthenia Gravis Foundation of America. And we look at patients are not happy with the side effects that they experience with our treatments. On average, more than a third of individuals are dissatisfied. And if you're on corticosteroids, that number jumps to in excess of 80%. People really hate the use of prednisone. And then there's a broad range of individuals who are dissatisfied with the time it takes to see a therapeutic response. We know that the majority of our drugs will take some 4 to 6 months to start working. Azathioprine may take 10 plus months, and therefore to achieve reasonable improvement, we're talking somewhere between 18 months and 3 years. And people don't like that, and we can fully understand that. And then there's a population who are dissatisfied with the degree of efficacy that they've achieved. And more than a third are dissatisfied with the inconvenience of how we treat them. Do they have to go to a hospital or an infusion center? Or does someone have to invade their home, as I call it, to administer intravenous products like immunoglobulin, etc., or rituximab in an infusion center or hospitalization? All of these affect the quality of life that patients experience. And what I'll attempt to show you that new targeted therapies have improved the adverse event profiles tremendously. And patients are going to demand a better quality of life as part of our overall treatment program. Heretofore, we treated patients with high-dose steroids, for instance. And if they put on 20, 25, 30 pounds, 10, 15 kilos, we said, you know, that's part of our treatment. We're sorry, but we're trying to get you stronger, and we live with it. If we put you on azathioprine and you develop florid basal cell or squamous cell carcinomas of the skin, that was part of the treatment that we had to live with because we had no alternatives. In this decade and going forward, we have new therapeutic options that will change that. And patients will ask for that. Let's step back and look at mechanisms of disease to try and understand how we can manage these individuals. And when we look at the pathogenesis of myasthenia gravis, we're talking about multiple disease mechanisms. We're all familiar with the antibody blockade of the acetylcholine receptor by antibodies, by acetylcholine receptor antibodies. And by their binding to some epitope on the receptor complex, we then sterically hinder the ability of neurotransmitter to get to the binding site. Very rarely does antibody bind to the direct binding site for transmitter. But the net result is the occupancy of one or two of these binding sites takes that receptor out of function. And if enough receptors are non-functional, the end plate potential generated by depolarization cannot reach action potential threshold, and that muscle fiber drops out. And if enough of them drop out, significant weakness occurs. So this is mechanism one, functional blockade. Mechanism two is that the binding of antibody to receptors cross-link these receptors and then facilitate a normal turnover process. Receptors are internalized, degraded, and new receptors come to the surface every 7 to 10 days, depends on muscle, depends on species, and the binding of antibody accelerates this process, again leading to a net loss of available receptors, a reduction in receptor density, such that we impair the ability to generate an action potential from a smaller end plate potential. But neither of these mechanisms explain this electron micrograph here on the right. And this is work elegantly done by Andrew Engel at the Mayo Clinic in the mid to late 1970s. And in the left panel, you see the normal nerve terminal here in the upper right portion, the neuromuscular junction, and the postjunctional folds here in the lower left, and in between the synaptic cleft. And the dark staining that you see is presumed to be antibody, or the location of antibody and the receptors. If we stain with Bunger toxin, this area will light up, and Bunger toxin binds irreversibly to the acetylcholine receptor. If we stain for immunoglobulin in a myasthenic animal or human, this would be the location that you would identify antibody binding. But on the right, these postjunctional folds, this highly organized region, is gone. And this is an intercostal muscle biopsy from a severe myasthenic patient, or a muscle from a severe experimental myasthenic animal, and one sees the absence of these postjunctional folds. And the question came, why? And we now know the answer, of course, but at the time, it was felt not to be due to circulating antibody, the binding of antibody, but rather the presence of complement. And complement was actually identified in the membrane debris field of these biopsies. And we now know that antibody binding to the acetylcholine receptor, as shown here, activates C1QRS of the complement cascade, ultimately leading from activation to the formation of the membrane attack complex, or the terminal complement complex, this ring-like structure, which literally develops pores or generates pores through the tissue membrane with leakage and ultimate destruction. So here on the right is the normal neuromuscular junction with these very architecturally beautiful postjunctional folds. The receptor site is here in orange. Here's antibody in gray to the receptor site, and then the activation of complement C1q of the complement cascade, leading to the formation of complement and the ultimate formation of this membrane attack complex with components of C5b, 6, 7, 8, multiple copies of C9 that then lead to this membrane destruction. And from peaks and valleys, we go to rolling hills. The result of all of this is that we lose the ability to pack receptors here densely. And if you take this membrane and flatten it out per square size, meter, whatever, we have far fewer receptors per unit. And this too leads to a failure of synaptic transmission, as we're unable to generate a significant end plate potential to reach action potential threshold. So the complement system comprises of more than 40 proteins in blood and surface, and they're named by a number in the order in which they were identified. It's a surveillance system, and it discriminates between healthy tissue and abnormal tissue, cellular debris, apoptotic cells, or foreign intruders. So it's our first line of defense against microbial invaders, and it also is involved in inflammatory and other immunological processes. However, in selected disease states, rather than being in our favor, there's an upregulation in the terminal complement pathway, leading to membrane destruction, as I've shown in the prior graphic. These are red blood cells in a patient with paroxysmal nocturnal hemoglobinuria, and one sees multiple membrane attack complexes here on the surface, literally drilling holes through the cell, ultimately leading to lysis of the red cell and failure. And this is what's going on at the neuromuscular junction. And so the complement system is tightly regulated predominantly in our favor as a surveillance pathway. But as I said, in selected situations where there's an aberration and an activation and upregulation, we get unleashed terminal complement expansion, and the result is tissue death. This is just a very simple schema of the complement pathway. It is much more complex than this. There are actually 3 complement pathways. The classical pathway, which we're most interested for today's talk, but there's another way to get into the system, the lectin pathway and the alternative pathway, and I'll speak about that in a minute. And so classically, we move down through this step through C3 to C5, and then C5 can be split into C5a and C5b, and each have their own pathways which work in our favor for the most part. We are most interested in this terminal complement pathway from C5b through 9 because it's the one that forms the membrane attack complex. And there is a lot of basic science, which I will not show you in myasthenia, demonstrating that this is the pathway that leads to tissue destruction of the neuromuscular junction. And so pharma has been targeting C5 as a therapeutic option to control the immunological attack of myasthenia. Targeting C5a in experimental models does not work. People are now starting to think about the alternative pathway, and there is a study that is just starting to be launched that will look at an oral factor D inhibiting C3 to see if by blocking this, will we have similar effects of the success that we've had in blocking C5. So you all know about this, but let's just set the case here that we know that myasthenia gravis is T-cell dependent. It's complement and antibody mediated. Antibody is the basis by which complement is activated, and then the resulting attack by these varied mechanisms to impair synaptic transmission. And one would argue that the complement attack is the primary focus. And I would submit to you, where I live, our weather threat is hurricanes with winds in excess of 150, 170 miles an hour at times that are literally destructive. And we board up homes that are on the coast to protect the onslaught of the wind and the waves in the sea. And so too, one could argue that complement needs to be dealt with early and quickly in order to prevent its destruction. Why do you want to have to rebuild your house after it's been destroyed? Let's protect it from the start, if you will. 85% of patients with myasthenia gravis have antibodies to the acetylcholine receptor, and those antibodies are predominantly of IgG1 and IgG3 subclasses. There are antibodies to other protein determinants at the neuromuscular junction. One is muscle protein kinase, specific kinase. That's IgG4. And we know that IgG4 does not or only minimally activates complement, and complement therapeutics in myasthenia gravis will not work. The latest antibody in the arena is one to LRP4. It's still somewhat controversial. Some people do not believe it's pathogenic. I personally believe it is, and it's predominantly IgG1. We have no information about the role of complement in LRP4 myasthenia, and the material that I will speak about and talk to you about deals with AChR positive myasthenia gravis. And we've already talked about how antibody binding activates the complement cascade. So let's begin with the case. And so this is a fellow in his 50s. At age 75, he developed subacute bulbar weakness. He has a rapid progression to involve ocular, bulbar, and limb domains. He is AChR antibody positive, and he has a decremental response to repetitive nerve stimulation in his trapezius muscle. And he had a crisis on one occasion following surgical thymectomy within the first 8 months of disease onset. But here's his treatment course. He's been treated with cholinesterase inhibitors. They work partially, and they only work when he takes the drug. And he's been on these for nearly 25 years. He had been treated with high dose daily and then alternate day prednisone with only limited improvement for nearly 20 years. He had a thymectomy very early in his disease course that did not help him at all. He's had intermittent therapeutic apheresis, plasma exchange, with which he gets markedly better, but as you know, lasts only a short period of time. But he's used that intermittently over some 20, 25 years. Intravenous immunoglobulin, 2 grams per kilo, didn't help him. He was tried on azathioprine, what I would say is a low dose, and for too short a period of time, and he had no improvement with that. He was tried on cyclophilin, cyclosporin. He had some improvement for 20 years, but clearly had still significant residual. And he was put on mycophenolate and did not get better at all over the course of 6 months, which I think is a reasonable trial. And so then one has to say, what do you do for this guy? And there are varied answers, and each would have their own based on what's available to them. Some would argue that you go back and retry azathioprine because it probably doesn't take, it takes at least 8, 10, maybe even longer months to start working, 3 years for full benefit. So maybe he wasn't treated adequately with this. Some would argue that you treat him with plasma exchange on an ongoing regular basis. But in many areas of the world, it's not readily available. And in my country, we have to go to specialized hospitals that have it available. And so depending upon where you live, this may or may not be feasible. And so this fellow struggled. And I will tell you that he was housebound. He could not drive. He could not participate in sports. Golf was his passion, and he was unable to do so. And so he actually was enrolled in a phase 2 trial with eculizumab Soliris, and within 3 weeks had unbelievable improvement. such that he was able to go back out and golf. He could climb stairs, he could drive, and he was feeling so well that he took his chainsaw and cleared an area of his land of trees because he wanted to have a garden. And so a guy with nearly 25 plus years, more than 25 years of fairly unresponsive myasthenia gravis to multiple therapeutic options, turned the corner with complement inhibition. So to date, we've had 5 clinical trials. You're most familiar with eculizumab in its REGAIN trial and then the open label extension. This is a monoclonal antibody that targets C5 and received approval in the US in October of 2017, and shortly thereafter in Japan, and then selected countries in Europe, and will be, is now available to you folks. There is a cousin of eculizumab that's called ravulizumab. This is actually the same drug, but it's engineered to alter its half-life. And rather than having to administer eculizumab intravenously every 2 weeks, ravulizumab allows us to administer it every 8 weeks. Phase 3 trial is complete. It will go to the FDA later this year in 2022. And the results of this phase 3 trial will be presented at the American Academy of Neurology meeting next week in Seattle, Washington. Zilucoplan is a macrocyclic peptide that also targets C5. It's administered by daily subcutaneous injection. That phase 3 trial is complete. It will go to the FDA again later this year, and the results of this trial will be presented at the Myasthenia Gravis International Conference, which will be held in Miami between May 11th, 10th, 11th, and 12th. I already mentioned to you that there is an oral factor D inhibitor that utilizes the alternative pathway of complement, and that trial is just starting to get underway. And the other one is a combination of pozelimab and cemdisiran, which targets both C5 with pozelimab and is also an siRNA that is targeting the production of C5 in the liver. And this trial is just started. There have been 2 patients, I think, enrolled, and so we have no information for that. And so there's large interest in targeting the end effects of complement as a therapeutic tool for MG. And let's talk about the REGAIN trial, because my suspicion is all the other trials will follow similar results, looking at their phase 2 data, because that's the only thing we can compare. And so this is the REGAIN trial. I'm sure you're familiar with it, but let's just review it. Red is placebo, blue is active drug. This vertical dashed line here represents the rollover time from the blinded phase into the open label extension. And one sees that in blue, there is a very rapid and robust decline in the MG-ADL score, which was the primary endpoint as mandated by our regulatory agency, that reaches a nadir somewhere around 12 weeks. And then that response is sustained. And here it goes out to 130 weeks. And the error bars get bigger because the numbers in each cell are smaller, but we now have data out around 250 weeks. In red is the placebo. And like all MG trials, we have a significant placebo response, and the highest I've seen is about 60%. And this is a real problem for us. And we haven't figured out a way to minimize it completely. But one sees that at the rollover point into the open label portion of the trial, there is also a very similar rapid and robust decline in the MG-ADL response. And this is change from baseline on the y-axis. that then parallels those who were originally on eculizumab and continued forth. At this point in time, we've taken out the entire placebo response. So this is true drug effect. And one sees this very rapid and robust decline. And all of this is statistically significant using last observation carried forward statistics. Now, I will tell you that the original trial did not meet the primary endpoint. And this is due to the fact that the statistical analysis that was mandated by the regulatory agency was one called worst rank analysis. And we could go into the details as to why it failed later in the question and answer period if someone wants. But when using more standard statistical methodology, this was a highly positive trial. And the thing that saved us was the fact that there were some 22 pre-specified measures in the statistical analysis plan of the clinical trial, and 18 of them, those not related to the MG-ADL score using worst rank analysis, were highly significant. This represents the quantified MG score, which is a more physician-centric measure, and therefore the placebo response in red is less, but one sees this very active drop as well that is highly significant. And then at the rollover, patients in the placebo arm follow a very similar pattern as the active drug arm did originally, and then carried forward with very similar, highly significant responses. This shows the composite score. It's an admixture of the two, the MG-ADL, patient-centric, QMG or physical exam, physician-centric, and it too follows a similar path. The quality of life instrument also, and this is one that is fraught by many external forces, if you will, and the slope is not as steep as we saw in the previous slides, but it too shows a significant benefit that is carried forth. And so all of the metrics that we've used, and we'll come back and talk about metrics in a bit, all of the metrics used supported efficacy in the clinical trial. Now, this is a population of patients in orange who are late responders. They did not demonstrate this very rapid and robust response that I've been showing you in the prior slides. And this is the MG-ADL score. But it took substantial time before we started to see a significant change from baseline. We don't understand this. We have some thoughts, but we don't have a good explanation as to why these are slow responders. Despite this, when we look at complement inhibition in them, they all had nearly full complement inhibition beyond detectable range. So it wasn't due to the fact that we were not inhibiting complement. Complement was readily inhibited, yet these individuals responded slowly. We used to say that if you did not have a meaningful response within 12 weeks, then it's unlikely that you're going to respond. And we now have to change our thinking, and they may have to be treated substantially longer than that before we decide that this drug is not working and we need to abandon it. This is one of my favorite slides because it's telling us something that we have yet to explain and that we need much more information on. It's a huge data gap. This is the REGAIN trial just reoriented. And the blinded portion is below this dashed line here. Blue is active drug, red is placebo. And as I showed you before, people had a robust and rapid response. And at the end of 26 weeks, 61% of patients had a marked improvement, significant improvement, as did 42% of the placebo, of course. Yet this was significant. But then look what happens over time. Over the following 130 weeks, we see increasing numbers of patients getting better, 85% of them, in fact. And those who transition from placebo to active drug, they too get better, up around 93%. Remember, these patients were quote unquote refractory, failing multiple therapies. And the trial definition was at least 2 immune suppressants over the preceding year, or 1 but requiring chronic IVIG or plasma exchange. So what is going on that allows this population of patients who had failed everything else, knocking out various aspects of their immune system, to achieve this kind of a response? Are we rebuilding these post-junctional folds? Is the huge question. And we don't have good data for that. It's an area of interest for some folks, but it still remains to be seen. More impressive are those who achieve minimal manifestations, a clinical state in which, in the eyes of the investigator, there is no functional weakness whatsoever. By the end of the blinded phase, 25%. By 136 weeks, nearly triple of those. Again, raising questions that are just absolutely fascinating. And I wish I were about 30 years younger and this could become my focus of work. So what else does this do for us? Well, let's look at exacerbation rates of myasthenia. And we're looking at this in number of events per patient year. And so in the 1 year prior to the start of entry into the trial, we have about 105 events per patient year. And with treatment in the blinded phase, as well as the open label phase, that number drops substantially, 74% reduction. Let's look at hospitalizations related to MG. And again, pre-enrollment in the trial, we're running around 79 events, down to 13. More than 80% reduction. So the impact on quality of life, the impact on disease course is demonstrated in these two here. Substantial improvement. When we look at the use of the rate of exacerbation and the use of rescue therapy during the clinical trial in the first 26 weeks, those who are responders to eculizumab, there was 1 exacerbation, 1 use of rescue therapy. Those who are not responders, that subpopulation I showed you, were 12 and 12. And those who are in the placebo arm, 21. So comparing 21 to 1, one can envision the marked impact that we've had with the use of this drug. In terms of safety, and again, we're looking here on the left, placebo. Here is eculizumab in the blinded phase, and here is the combined in the blind plus the open label extension. Headache and nasopharyngitis were the most common. Some patients with diarrhea. There were some infections, typically upper respiratory tract infections, and then smaller numbers of other incidents. There was no patient death related to eculizumab in this trial, and there was patient death too that happened after discontinuation from the trial. One was due to a myasthenic exacerbation, and the other, if I recall, was due to hepatic failure due to an unrelated event. No meningococcal infections within the trial, but I believe that's a numbers game. We're going to see them, and it behooves us that we have to immunize these individuals based on your standard of care. In the US, it's with both the quadrivalent and the B serotype, and that should be administered at least 2 weeks prior to receiving a complement inhibitor. And if that is not possible because one wants to use it more urgently, then one has to cover them with an appropriate antibiotic recalling that certain antibiotics may aggravate myasthenia. And so one has to be careful in that regard. So what's the clinical approach? And so we've already said this is a rare disorder, antibody-mediated, complement-dependent, and the sine qua non is first described by Sir Thomas Willis in the 1600s. An anatomist was variable weakness made worse by activity and improved with rest. And he talks about a woman who could speak readily and freely, and under the course of with her discourse became mute as a fish, and then recovers her voice within an hour. And this is a 14-year-old woman with myasthenia that I saw back in the late 70s, and she has obvious ptosis of her left eyelid. And within 30 seconds, that ptosis worsens to near total closure. She now has ptosis on the right lid. And if I asked Chrissy to close her eyes and rest for a minute and then reopen them, she'd look like the left panel, the characteristic feature of MG. A snowflake disorder, both genders, all ethnicity, where we have neuromuscular expertise, but subsets do exist. We've already spoken about MuSK, for instance, that impact our therapeutic strategies. And complement inhibition would not work, for instance, in MuSK-positive patients. Associated malignancy with thymoma in 10 to 15%, the majority of which are benign, but if extension through the capsule, we would consider that malignant. And then this quote unquote refractory term in some 10 to 20%, which I believe is much higher than that if we take into account quality of life, adverse event profiles, etc. We've spoken about this and we won't belabor the point. 85% are AChR positive. Some 5% have antibodies to MuSK. About 1% are due to LRP4. And that leaves us with about 10% of seronegative. But I would argue that seronegative is not really true, because my suspicion is that many, though I don't know the percent, do have low-level non-detectable antibodies using the typical assays we have available to us commercially. If we use cell-based assay techniques that are now starting to be developed, hopefully on a commercial basis, but the work has been done by Angela Vincent at Oxford for a couple of decades now, then this number falls and AChR positive increases. And we know that there are other protein determinants at the neuromuscular junction, Titin, for instance, DOX7, for instance, that may also be targets that could be autoimmune acquired MG. We classify MG based on the characteristic degree of severity. This was originally developed at the University of Virginia by Dr. T.R. Johns, and then incorporated by the Myasthenia Gravis Foundation and modified. And we classify them as 1 through 5. My belief, it should be 0 through 5, with 0 representing clinical or pharmacological remission. But 1 is restricted ocular myasthenia, and all other muscle groups are normal other than eye closure. 2 is mild, 3 is moderate, 4 is severe, and 5 is ventilator dependent. 2, 3, and 4 we can subclassify either to A or B, and those which predominantly affect limb or axial muscles with or without ocular involvement, and may have milder bulbar involvement. And B form are those who have predominantly bulbar respiratory involvement with lesser involvement of the limb, axial muscles, eyes, etc. And we found that this is a dynamic classification. It changes as the patient changes, but one can use this to get a sense of how one's patient is doing in terms of a population or longitudinally over time. With pharma's interest in myasthenia and the development of clinical trials, we had to develop clinical outcome measures that are listed here at the top. And I'm going to urge you to adopt some of these because they're very simple to use. Others are not. We'll start with the QMG, which is the oldest, the quantified MG score, which is an assessment of muscle strength. It's essentially a physical exam, but is scored differently. Its limitations are the time it takes to implement this. And for those who have busy clinics where you don't have inordinate amounts of time to spend with a patient, this does not become feasible and serves as a research tool. I'm going to jump to the MG-ADL score, which is a patient-centric outcome measure. It's the primary outcome measure of all phase 3 trials based on the US FDA's mandate, if you will. And it looks at the functional impact of muscle weakness through 8 items covering ocular, bulbar, limb domains, respiratory domains. It takes 2 to 3 minutes to complete. And I would urge you to adopt this because it tracks pretty well with QMG scores and the composite score, which we'll speak about. The composite score is an admixture of these two, but the QMG elements of ptosis, double vision, neck flexion, extension, hip flexion, etc., can be incorporated from your physical exam and then scored appropriately. So it takes a couple of minutes to fill out once you've done the other two. And it's a weighted scoring system. We've tried to get this adopted as a primary outcome measure, but regulatory agencies have been a bit more reluctant to let us use it. So it's always a secondary outcome measure. But these three are the primary players in terms of giving us insight as to what's going on to the physical components of MG. The QOL, and it's been revised to the QL15R now, is a scoring system that's 15 items. It's now been condensed into 4 answers rather than 5, and it takes a few minutes to complete. The trouble with it is it's intruded upon by one's depression, by their back pain, their, whatever. And so while it's designed to be specific for MG, unless the patient is continually counseled to complete it only in the context of their MG, and sometimes they can't, there's some intrusion and is not as sensitive as the others. If you have to pick one, I would advocate you pick the MG-ADL score. And this is what it is. We're not going to go into detail here because of timing, but it's looking at functional impact. And one simply uses an algorithmic approach. Do you have difficulty talking? Yes or no? No. You scored a 0, move on. Yes. You then say, is your difficulty intermittent? Is it slurring or nasal speech? Or is it constant slurring or nasal speech? And then they'll answer that. If 1, move on. If 2, you then query as to whether people would have difficulty understanding them. The recall period is variable based on how it's been used. I advocate a 7-day recall period. Others have used longer than that because I don't think you can remember what things are like more than 7 days. And it's the average of how they feel. And so if they have only 1 episode out of 7 days of choking, to me, that's inconsequential, particularly if it happened on day 1, 2, rather than day 6, 7. A reduction in 2 points is clinically significant. So let's look at another case. And here's a 72-year-old woman doing very well in her usual state till January of 2021, develops ptosis in the left lid. 2 months later, she's got difficulty chewing. She has weakness in her arms. Her primary care physician makes the diagnosis of MG based on an internet search. Kudos to that individual. And she has diabetes, hypertension, and a prior TIA. She gets referred to neurology, confirms the diagnosis of AChR positive MG, and starts pyridostigmine 3 times a day and intravenous immunoglobulin, administered 5 daily doses, so 0.4 grams per kilogram per day, and she has mild improvement. Very soon after, represents to her local emergency room with 48 hours of rapid worsening. My suspicion is the IVIG was wearing off as there was no plan for ongoing therapy. She gets treated with apheresis because that's what's preferred at this institution. She has marked improvement, and she's begun on modest prednisone and mycophenolate simultaneously at the day of discharge. But 5 days later, presents to the ED with an inability to swallow, unintelligible speech, can't oppose her jaw, and has severe generalized weakness, grade 3 out of 5, approximately, and the ED discontinues her prednisone, stating it's ineffective. I would submit to you that she was having a prednisone-induced exacerbation of her myasthenia gravis. She's hospitalized, intubated, and transferred to the university, where she's treated with intensive plasma exchange, adjustments in her pyridostigmine, and her mycophenolate dose is increased to 3,000 milligrams daily, 2 divided doses. And these are her scores. Remember, we said that ADL score of 6 or higher is indicative of moderate to severe disease. Hers is 16. Her MMT is very severe with 40 and her composite 33. She suffers a complication with her plasma exchange because it was done through a subclavian catheter, and she develops a hemothorax. And while improved significantly with plasma exchange, remains symptomatic, and then is seen a few months later, and here are her scores. ADL is slightly worse, MMT is worse, etc. So what do? Remember that this is an elderly individual. She's got diabetes, so steroids, in my estimation, are not very good. She's had a prior TIA. That plus the diabetes tells me that I do not want to use immunoglobulin. Mycophenolate is going to take some time to work. And so how would I manage her? In the old days, some individuals would consider ongoing repeated courses of plasma exchange. Others would consider rituximab, though in my opinion, rituximab is not overly effective in AChR positive MG. Or would you put her on a complement inhibitor? And the use of a complement inhibitor was chosen, and she was started on that. And within 3 weeks, she had an ADL score of 0. Her MMT score was 1 because of weakness in eye closure, and everything else was normal. And she was doing beautifully and remains on every 2-week infusions of eculizumab with continued maintenance of minimal manifestations. So the refractory definition, as I said, is controversial. It is developed by various clinical trial groups to meet a particular population they want. There is an international consensus guidelines through the MGFA. They say failure of 2 ISTs or the need of chronic plex or IVIG, or with significant adverse events. Estimates are as low as 5 to 8%, as high as 20. My belief is if you start taking these into account, the estimates go even higher. So we've made progress with targeted immunosuppression. In doing so, we've reduced side effects. We have much more rapid onset of action of our drugs. We now have the capability of treating patients who have failed other forms of therapy. We are on the way of developing different formulations, sub-Q, varied dosing with intravenous preparations, and depending upon how a factor D inhibitor works out, maybe an oral preparation. We have safety in pediatric populations, and there is an eculizumab trial in a pediatric population, 6 to 18 years of age. That trial is finished. The data is being analyzed as we speak. We do need information in childbearing patients, potential patients, women with pregnancy. There is data coming out of Britain in a PNH population that suggests it's safe, but those numbers are only about 100 patients, 100 pregnancies, so we need more there. And we need some insight as to its ability to use as a rapid reversal, a rescue agent for pending crisis or myasthenic crisis, and we have no firm data. There are a couple of anecdotal reports in the literature, but nothing more than that. And so with that, I would like to thank you for your attention to this, and I am very willing to answer questions for you.
Thank you. Thanks a lot, Dr. Howard. Very interesting talk. I was always afraid to give eculizumab to someone who's in his 70s, but you were brave enough to give it, and no complications.
I have several patients over 65 that are receiving it and doing well.
My question is here, if I see your data there, the placebo effect catches up after a few weeks, right?
Yes.
So,
well, what do you mean catches up?
I mean, they have the same effect as the treatment effect.
Yes, yes. And so what we saw is that with the regained population, can you still see my slides?
No, I'm seeing just questions and answers.
Okay. So at the rollover period, during the blinded phase, placebo improved, on drug improved even more. And then at rollover, when the placebo started taking active drug, they then paralleled the active drug arm. And so those who are on placebo, that placebo response is gone in those patients too, as well as those who start with active drug.
And I could see from the data you've shown that with the time you disperse the interval between the treatments, right?
The treatment interval is every 2 weeks.
But you don't prolong it later on, or you don't?
Well, that information is not readily available. There is a real world registry trial that's actually ongoing where some clinicians are trying to spread the effect. My own personal experience is a young woman who was on eculizumab, and this is a few years ago before we had pregnancy data, who became pregnant, terminated her pregnancy, but we had stopped the drug and she had a relapse within 2 weeks.
Oh.
We know that complement inhibition lasts about 14 to 18 days on average. Now, I'm sure everybody's different, and I'm sure there are some people who would benefit from infusions a little bit closer than every 2 weeks, and those who you could go a little bit longer. But the product insert, the company's position at this point, and most of us are saying we would treat it every 2 weeks in order to keep the disease under control. There is experience in PNH where if you miss a dose with PNH, the LDH rises very rapidly, and they're now at risk for thrombotic events. So you lose control of the complement activation very rapidly with missing a dose.
Do you have any head-to-head trial with rituximab, for example?
Yeah, there's no head-to-head trial with rituximab at this time.
Okay, let's go to the audience question. If the patient is controlled on CellCept and planning for pregnancy, should I stop CellCept?
Absolutely. Pregnancy and CellCept are contraindicated, and there is a high risk of a first trimester spontaneous abortion in pregnant women who are on mycophenolate. And the mycophenolate REMS program states this. And in fact, in the States, we have to sign a form that we've counseled the patient that if they're become pregnant, we have to discontinue drug, etc.
On the other hand, Imuran is supposed to be safe.
That's what people say, but I will tell you that there is some animal data. It's very old. It's back in the 70s, looking at second generation offspring who had chromosomal defects. And so if you gave Imuran to a pregnant rat and they were myasthenic, or not myasthenic, pregnant rat, their first generation was fine, but the generation that came from that litter had chromosomal defects. Oh. And so I have avoided using it in pregnancy because of that. But I have colleagues and literature suggests that it's safe. I don't know what the right answer is.
Yeah.
But
I have a handful myasthenia on Imuran, and at least their first generation are okay.
Good.
Another question here. Do you recommend C5 inhibitor as a first-line treatment for treatment refractory myasthenia gravis?
That's a great question. I think currently the cost of complement inhibition puts it into a restricted use. Ideally, if cost were not a factor, complement inhibition would be my first-line drug. Now, having said that, there's an issue because we're only looking at one of those three pathways that I talked to you about, and you're doing nothing to affect the effects of the antibody. And we have data in patients treated with complement inhibition in our refractory population long-term where single fiber EMG does not normalize. You still see an abnormality of synaptic transmission. So in the ideal world, I would use something that addresses the antibody, a B-cell depleter, an antibody clearer, plus complement together as first-line therapy for the best response. But we have a data gap. Is complement active throughout the course of the disease, or at a low level or high level, or are there periods of time where complement activation increases through exacerbation, through illness, whatever? And so can you use it intermittently with other things and maintain effect? We don't know. If cost were no issue, I would treat simultaneously the antibody as well as complement. But cost is an issue.
I mean, I have people who are stable on IVIG monthly course. I mean, if you calculate the cost, if you use IVIG on monthly base and eculizumab every 2 weeks, it will be more or less the same price. Then how would you convince our neurologists to start people on eculizumab, where they have to do vaccinations, especially in the light of COVID era?
Yeah. So fair point. And so I would say, all things being equal, if your patient is doing great on a current therapy, why would you want to change? One is the quality of life and the adverse events. Mm-hmm. So am I having to get the worst headache of my life every time I get IVIG? I would change. Am I in a job, or am I a housewife? Am I a mother? Whatever, where I'm having to take time off every period, whatever that interval is, to get my IVIG infusion. And does the switch to an every 2-week process alleviate that? May or may not be an issue. But I think you have to look at things other than just the strength. And it's the quality of life and the adverse events that in a person who is doing well that would force me to change. In my experience, a lot of our patients develop terrible headaches, and they don't like the IVIG. Now, the patient who has renal disease, the patient who's had coronary artery or prior transient ischemic attacks, a vasculopath, I don't like them on IVIG. I'm afraid I'm going to induce another infarction. And in 40 years' time, 45 years of practice, I've infarcted every organ system with IVIG. The eye, the gut, the lung, the heart, the brain, the kidney. And, you know, it's rare, but it happens. And so I'm skittish in people who have underlying vascular disease to use IVIG on a long-term basis. One set, you know, I'm willing to take the risk, get by with it, but chronically, I think I'm asking for trouble. So I would switch in that current.
Here's the question here. Patient is controlled on monthly course of IVIG and CellCept for 4 years, had thymectomy done. When can I stop CellCept?
Yeah.
I would ask probably the question, when I stop IVIG?
Yeah. I would stop the IVIG before I would stop the CellCept.
Exactly.
But the messages we're getting with CellCept is that in order to minimize the risk of exacerbation, one has to be on CellCept for a few years, but the investigators didn't define few. This is work that came out of Duke from Lisa Hobson-Webb. And then CellCept reductions were 500 milligrams once a year, no more frequent than yearly reductions. And that's how they would taper. So it's a very long duration withdrawal or reduction in CellCept. The problem that we saw was that when the CellCept paper came out, and the message was it was a failed trial because it wasn't better than prednisone, everybody wanted it off CellCept, and including my patients. And there was a significant number of them who did exacerbate, who did not respond to CellCept when I put them back on CellCept. For some reason, they became refractory to CellCept. And so one has to be cautious that if your patient exacerbates, you may not be able to recapture them. You're going to have to seek an alternative drug. So the underlying message is go low and go slow if you're going to start withdrawing CellCept.
And when would you stop CellCept if the patient is planning pregnancy?
Oh, immediately. I mean, if there's no time to wait, immediately. If they're planning, then I accelerate it and I bring them off between 6 and 12 months.
Oh.
But I don't cold turkey it unless it's absolutely mandatory to do so.
And how long would you keep eculizumab for refractory MG?
Till I had a better drug.
So lifelong.
Yeah, if that's all they're responding to, I'm not sure you're going to be able to get them off it.
And if the patient is planning for pregnancy, how long would you stop it?
Stop which?
Eculizumab?
I'm not sure I would anymore. There's data coming out, and I have a colleague who's had 2 patients with pregnancies who've done fine. I think you have to weigh the risks of their myasthenia versus the risks of the disease. And the data would suggest that it is safe, though we don't have large numbers of data. And if they had bad myasthenia, I would continue it, because I think the risk of worsening myasthenia on the pregnancy is far more dangerous.
Okay, so safe for pregnancy then.
With question mark, because we don't have.
There are so many medicines on the pipeline, right? Is there any oral eculizumab coming in future?
Not an oral eculizumab. There's this oral factor D inhibitor.
Okay.
And I'm aware of one other company who began preclinical work trying to develop an oral zilucoplan. But I don't know where that stands.
How many patients you have who are taking ocrelizumab and they are above 70?
8.
8, and they're all doing fine, no complications.
I have one patient who has not had a great response to eculizumab. My 85-year-old is doing wonderfully. But they've all done well other than this one fella, and he's not had a good response.
Have you noticed any increasing COVID infection on those patients? And in fact, if they get COVID, are they having more serious course or they're normal too?
Yeah, I think the numbers are small. My personal experience is that I've had 16 or 17 myasthenics develop COVID. Of that group, one had an exacerbation of their myasthenia. She spent 6 months in the ICU on a ventilator with a COVID lung, and who is now recovering from that. The others were never hospitalized and did well. 3 of them were after 1 dose of vaccination. The others all had at least 2 doses of vaccination. The Myasthenia Gravis Foundation has, it's called MG Care. It's a registry for patients with COVID, myasthenics who get COVID. And I've not looked at it in several weeks. There are about 400 patients in the registry. The majority do well. There are about 10 or 15% that exacerbate their disease. But this was very early in the course. We don't have good data with a population that have been vaccinated and boosted. But my own personal experience is that appropriate vaccination and boosting is very protective.
And how long before injection you would vaccinate them? Is there any time frame?
So with eculizumab, it does not matter when you vaccinate them. It's not the complement inhibition will not alter the response to develop a vaccine response.
So you can give them vaccine even after you're getting the injection.
For things like COVID, et cetera, yes. Now, for meningococcal vaccine, you want that at least 2 weeks before, so that you have an appropriate vaccine response.
Okay. And who are the youngest patient you've been treating?
Of MG, youngest, or with COVID, with eculizumab?
With the eculizumab.
My youngest eculizumab patient was 13. She was in our pediatric trial.
You do start them below 18.
She was in a clinical trial where we were enrolling folks. She was 13, has done beautifully. She was in a wheelchair when we started her. She was on Cellcept and prednisone, high-dose prednisone. And within 2 months, well, within 3 weeks, she was walking, no need of a wheelchair. And within 3 months, she was essentially normal, has been that way now for 4 years.
We will be soon starting our own first patient, hopefully. On next meeting, I will be able to tell you the results.
That's great. Great to hear. Well, if you have questions at any time, don't hesitate to email me. Happy to answer them.
Sure, sure. What's the connection between thymus gland problem and myasthenia gravis?
Yeah, so that's a fascinating one as well. If you look at the thymus gland, there are actually muscle cells in the thymus gland, myoid cells, fetal cells that express receptor. The trouble is that the receptor that they express is not the adult form, but is the fetal form of the receptor, which has a different subunit of one of the five. And we believe, though we don't have the best data, we believe that's where the site in the break in immune tolerance occurs. And because there's enough similarity, homology, to the receptors out in the periphery, they get the attack as well. And it's why the belief is that if you do thymectomy, that one sees improvement because you're taking away the site where the break in immune tolerance occurs. The question then comes is, well, why does it take long? Why doesn't it happen? And we know that there are memory cells that have many years life duration. And once those memory cells are out in circulation, they have the capability of initiating an antibody response.
So as far as I understood from you, myasthenia gravis is T-cell mediated, right?
Predominantly T-cell mediated, antibody dependent, and complement dependent.
Okay, so theoretically, then rituximab shouldn't be responding well, because
So if you're looking to take out antibody in those B cells, one would postulate rituximab would work. And in MuSK, it works beautifully. It's my drug of choice. But in AChR, I don't think it's targeting the right population of B cells. And the CD20 expression on B cells is very narrow. And so we now have a trial using a CD19 inhibitor, inelizumab, which is now approved for NMOSD, which targets a much broader range of the B cells, including plasmablasts. And I think that's the key. My suspicion is that this drug will be effective because of this broader range.
It's now almost 2020 or 2018. We have 2 more minutes. I have a question here. Is myasthenia gravis inherited?
So the autoimmune acquired form of myasthenia is not directly inheritable, but 3 to 4% of our population have a primary relative with myasthenia gravis. And there is work that came out of NIH looking at about 1,400 myasthenics. And Italy has another study with similar numbers where there are certain genetic markers or certain genes that get upregulated that have to deal with autoimmune disease. So there is no direct genetic correlate to MG, but there are various hotspots and targets within our genetic profile dealing with autoimmunity that then predispose you.
In your lecture, you mentioned about DOC7 as an autoimmune myasthenia gravis. So far, I know it's one of the congenital myasthenic syndrome.
And overwhelming, they are congenital. There's one case, and it's being debated, that is felt there was an antibody directed at DOC7 that had myasthenic symptoms.
Because I have 2 family members with congenital myasthenic syndrome. They have DOC7 and they have thymoma.
Oh, wow. Fascinating. That's reportable.
Yeah, we reported this case actually. And the question was whether we should do thymectomy or not. And I believe we ended up doing thymectomy in both.
Yeah, I probably would have too. Taking out the tumor, I would have taken out the gland as well. Did you try and treat them with something like plasma exchange, which would, if someone responds to plasma exchange, to me, it has to be autoimmune. And a congenital form of the disease would not respond to plasma exchange. That would be another good test.
I never, but I would probably do it. Okay. Dr. Howard, thank you very much for your interesting talk. We conclude our meeting for today and the course. And it was very interesting lecture and very interesting topic. we hope seeing you next future.
Great.
This is your second, I
Second
believe
trip.
that's your second time with us. So.
Yes. Well, thank you, Dr. Al-Madani, for the invitation. It was a pleasure to speak to all of you.
I'm honored
Everyone
to
have a
see
great evening.
We are all honored to have you in this meeting.
Well, thank you for your confidence and invitation.